Awesome. Thank you for joining me, everybody. My name is Ara Balkian. I'm a senior strategic advisor for Innovative ECMO Concepts, and we're really here to talk about something that I consider fun, which is the economics of ECMO. So we're going to get pretty deep into the numbers and the finances and charges and costs, which I think folks who maybe are involved in ECMO clinically or administratively will hopefully enjoy. Here's the agenda for today. We should be done in time, and hopefully I've got some time for questions. I can't see the chat questions as I'm presenting, but if we have time, I'll get to it then, or maybe you can unmute yourself and we can talk about it. Here's the agenda for today. Let's get into it. So my background is as mentioned, I've been with Innovative ECMO Concepts for about a year or a little bit, almost a year and a half. And in my role, I do a lot of what we're doing now, which is showing hospitals how they can structure their program for it to not be clinically appropriate and for the safety of their patients, but financially feasible. We all understand what hospitals are going through these days. Many of them are pressed for their profits, and they're looking for ways to become financially more stable. And the more we can show that this program is not just financially sound, but is thriving, the more resources it can get and the more it could grow. I've been at Children's LA for about 25 years as the inpatient chief medical director, still practice as a peds hospitalist and teach at the medical school. And I do, in that medical director role, I do a lot of denials management and clinical documentation improvement and other utilization management work. So I'm familiar with the reimbursement models, not just at our hospital, for others. And lastly, I founded and lead Pediatric Resource Group, which is the only peds-focused healthcare consulting firm in the country. And we have a number of services, some of them being around reimbursement models and optimizing revenue and cost for hospitals. So in all three of these roles, I think I've got some background in this. Innovative ECMO Concepts really is a company that provides, comprehensive front-to-back support for ECMO program development and management. It was founded 10 years ago by ECMO clinicians, ECMO specialists, which is great, so they know the clinical side. Trains over 1,000 providers annually, and you can see how many ECMO hours they have there. The number of services provided by the company, you can see staffing, coordinators, specialists, and perfusionists, multiple modes of education, transport support, and program services as well. And part of that is revenue cycle assessment you see down at the bottom. So we see hospitals saying, we lose money on ECMO, or we want to start an ECMO program, but we have to show our CFO that there's a financial positive return on investment, and we can help hospitals do that. This will be recorded and put on the Innovative ECMO Concepts YouTube page. So at a high level, what we'll start with are what are the benefits of ECMO? First and foremost, I'm a clinician. It saves lives and improves outcomes. And the list of conditions that are amenable to ECMO really keep growing year after year. And I think that will continue. There's a number of studies, and here's just one here during COVID, where being placed on ECMO versus mechanical ventilation can significantly improve mortality. So I think, I wouldn't be doing this if I didn't believe in ensuring ECMO was viable in hospitals and able to grow, and I support that. It also enhances recruitment and retention. We see a lot of hospitals that want to recruit intensivists or surgeons, and a lot of these clinicians want to go to where ECMO might be available in the future or is available now. They want to go to where the highest intervention possible is available to their patients and also their families. They're going to be living in that community. And then lastly, which is the purpose of this talk, is generating profitability through ECMO. It's one of the highest reimbursed services for all payers, and I'll show you that. What we're seeing a lot in the payer landscape is the push to move surgeries to an ambulatory surgical setting away from the hospital to lower cost settings. You can't do that with ECMO. It's going to remain in a hospital. And that's just the way it's going to have to be compared to other higher margin services that can be moved away. And then there's a halo effect really around growing cardiac surgery, neonatal care, trauma, ECPR, ECMO CPR is amazingly growing around the country, which is great because the outcomes of that are wonderful. And to have that, you have to have an ECMO program in place that's able to do this. There are some side benefits, the U.S. News and World Report, if your hospital is interested in that, there are some points associated with having an ECMO program for NICUs and other types of service lines. So there are other benefits beyond what I've listed here. And on the reimbursement side, really, we're going to talk about hospital fee or hospital billing the majority of the time. We'll get to professional fee near the end. But really, the big difference is for the hospital side, there's one bill for the entire stay compared to professional fee where we all bill daily. Hospital fee, there's hospital coders that read all of our records and code based on coding guidelines and rules based on documented diagnoses that are supported. If a diagnosis isn't documented, then it can't be coded and there's a risk of lost revenue and you're underrepresenting severity, and your case mix index or CMI will be lower than it should be. On the professional side, we bill based on E&M level or the CPT with supporting diagnosis. And if the diagnosis isn't supported, then there's a compliance risk of being denied. So on the hospital side, we really like to think about it as the ECMO revenue cycle. Revenue cycle is really just a term to talk about the process and structure of billing and collecting for patients as they get admitted to the hospital. Pre-admission on the front end, what are the reimbursement models? That's the major element of what will drive a lot of hospital behavior. And ECMO carve-outs are an important part for this specific care, daily charges. We'll get into all of that. That's the front end. Mid-revenue cycle is about professional billing for the physicians that do accurately. ECMO daily charges, that for all ECMO charges are they accounted for properly. Certain types of ECMO cases, depending on the payer, are amenable to something called clinical documentation integrity that ensures that all the diagnoses have been documented and coded for. Utilization review to ensure appropriate length of stay, because the majority are going to be paid one payment for the whole stay. So you want to make sure both clinically the length of stay is appropriate, but financially as well. You want to ensure that denials are prevented concurrently. You're not going to see a lot of clinical denials for these types of patients because they're pretty sick, but there are a number of other ways payers look to deny us payment for the case. And you got to make sure for high resource services like this that it's addressed to in a timely manner. Then on the back end, getting discharge and transfer status correct, we've got a few slides on that near the end. Is the case coded accurately and in the correct DRG? If you're wondering what a DRG is, you will know after this talk. And then ensure that these types of cases are prioritized because they're specialized and unique, and you want to make sure they don't just fall into the normal queue or revenue cycle. Well, let's talk about the front end. A major question that we always ask a lot of clients when we just talk about them, and maybe you've asked your own hospital, is what is your payer mix? What is payer mix? It's just the percentage of your discharges in any given time frame that are discharged with certain types of payers. Medicare, obviously federally funded program, Medicaid, which is state by state, and generally has to have a certain poverty limit or disability, or commercial payers, which every CMO wants more of. So you have to understand what is our payer mix. This is a simplification. There's other as categories. There's some TRICARE or Champus Medicare military payment in the past, and there's self-pay. There could be others here, but these are the big ones. And then when you think about the payment model for each of those payer types, Medicare is going to be paid on MSDRG, which once again, you'll know all about that in a bit. Commercial is going to be a mix based on what your contract is. Some could be MSDRG, some are APR, some are per diem. There's really a mix throughout the country, depending on your region and leverage within the community. Medicaid is going to be paid by APR, DRG, MSDRG, or per diem, and we'll get into that in a second. This is a map of every state's Medicaid program. Remember, Medicare is a federal program. It's run by the federal government. There's one rule that applies throughout the country. There are now Medicare Advantage plans that can have some variation region by region, no doubt, but they still have to abide by a lot of the Medicare rules. Compared to Medicaid, which is jointly funded by the state and the federal government, and it's very unique to each state. You see that the dark blue states that are paid by the APR-DRG model, there's about 31 of them. The gray ones are MSDRG, which is how Medicare pays for adult care. It's 12 of them, and there's still 7 states on the per diem model. We're gonna walk through what all of those even mean. And this can change year to year. APR-DRG is owned by 3M, the same company that makes the Post-it notes, and they're pretty aggressive in trying to go out throughout the country and getting state Medicaid programs to move over to their model. About 55% of pediatric discharges around the country are discharged from a Medicaid payer. So for that patient population in particular, this payment type is important. What are different payment models? So there's bundle payments that pay for an entire episode of care Joint replacement is a good example. We'll cover some pre-op visit, surgery, and a certain number of days post-op. And oftentimes the professional fee, we talked about earlier, is bundled into the hospital fee, which is unique compared to the other payment types. There's case rates, which is going to be a set amount paid to a hospital for, for these cardiac transplants, we're going to pay you $1.2 million. Then it's on you as a hospital to take the risk on how they do and about complications and if their length of stay is extended because of that. Capitation is really the Kaiser type of model where there's a fixed prearranged per member per month payment. We're seeing this now a lot where payers and IPAs are taking risk. They cover 20,000 lives. They'll get a certain amount of dollars for the year based on their risk and acuity of that pool of patients. And then they try to control costs by keeping patients out of the hospital. And if they do well and they don't spend as much as they brought in, then they have a bonus at the end of the year based on that. Percentage charges, that's usually the preferred type of payment for a lot of hospitals, though uncommon, that you negotiate a certain amount of percentage charges that you'll be paid. And why it's great, because charges oftentimes don't always have an underlying basis to the cost that they're covering, and we'll get to that in a second. Per diem is also very common, particularly in commercial payers. All of our commercial payers here at Children's pay per diem. It's Latin for per day. It's a contractually negotiated amount. We're going to pay you $4,000 per day, regardless of what you do or don't do to the patient. If they go to the OR or get an MRI that day, it doesn't change the payment at all. It can vary based on the unit the patient's on. And then there's diagnosis-related groups, which are what DRGs are. It's one payment for the entire stay. It will vary based on the variables of the case. We'll talk about that. It's used by Medicare and most state Medicaid programs. Okay, and there's different types of DRGs. What are they? They're really just groups of related diagnoses. I wish they would have named GRDs. It would have been easier to remember. There are multiple types of DRGs. There's MSDRGs, AP and APR. You saw that state map that had a variation of APR and MS. Medicare started using them early on. They were invented in the 60s from a professor at Yale, where he wanted to study resource intensity from one hospital to the other. And it's hard to do when charges vary so much. And he created this model to try to compare apples to apples. Medicare really exploded in 2007 when they used the MS-DRG or Medicare Severity DRG, which is still in place today. And then all patient refined DRGs is developed in the 90s by 3M and the Children's Hospital Association, though CHA has nothing to do with it anymore, and has significantly more DRGs for pediatric and neonatal population. So, which is great for states like mine that we have the APR-DRG model, because there's not a lot of neonatal and pediatric codes in the MS-DRG model. How is the DRG determined? We as clinicians document in the record about the patient. There are hospital coders at every hospital that read every single note, lab report, radiology report, path report, you name it. They probably know who are the great note writers, who are the ones with note bloat, because they have to, from that, pick one principal diagnosis that really was the reason for admission. So it's at discharge when this is all submitted. Up to 24 secondary diagnoses. You see the rest of the variables there. It goes into a computer program. Remember, I was talking about 3M coding APR-DRGs. They have about 95% of the coding market in the country. There's Optum and a few others, Adobe, that have some other coding software, but 3M pretty much has it all. And it then spits out one of 340-ish MSDRGs, and I say ish because each state also can adjust how many MSDRGs or APR-DRGs they have. So if you look at these numbers and it doesn't match how many there are in your state, that's normal. And there's some states that add some or remove some and change it. So if we think about the MSDRG model, we document, the coders enter all those variables into the encoder, spits out a base DRG with 3 severity levels. No complication comorbidity, or major complication comorbidity. And it's pretty easy in the MSDRG model. What is a major complication or just a complication? Because there's a list, and CMS puts out every year. So if that diagnosis is on the MCC list, that's an MCC. If it's on the CC list, it's a CC. So here's congestive heart failure. That's acute. It's a major complication comorbidity, whereas chronic congestive heart failure, as an example, is just a complication comorbidity. So this is how severity adjustment in the MSDRG world works. In the APR-DRG world, it's much more complicated. It's an 18-step process within the encoder. And based on the principal diagnosis and the varying types of secondary diagnoses and how they interact with each other, it spits out one of 4 SOIs, or severity of illness. Remember, compared to the 3 in the MSDRG model. And an APR-DRG world, every DRG has 4 severity levels. In the MSDRG model, there's some have 1, some have 2, some have 3, and we'll show you that. Briefly, before I show you that, the other element of APR-DRGs, as you saw there, once all these elements are placed, it spits out these severity of illnesses, but it also spits out the 4 risks of mortality. And this is where expected mortality comes from. And this is important for this talk because ECMO patients, unfortunately, can have a high mortality rate. And there's a table for PEAS, as example. There's a Children's Hospital Association puts out a expected mortality weight based on historical data. So a neonate with ECMO, severity level risk of mortality 4, has a risk of mortality of 0.352. You just multiply the number of severity level 4 neonates with ECMO you had times that number to get the number of expected deaths for that specific patient type. And that's where your expected mortality comes from. And then there's a mortality index, which is a quality indicator, which is your observed mortality over your expected, and you want it to be less than 1. You want your actual deaths to be less than was expected. So this is where the expected mortality comes from, which I think is important for us. So we document, they code, it goes into the encoder, it spits out an MSDRG with different severity levels. So here's COPD with major complication comorbidity, with complication or without. And it's this new concept now of a relative weight. All a relative weight is based on historical charge data. Where does this type of patient with this severity level fall in the scale of resource intensity? The higher the relative weight, higher charges associated with it, the lower charge associated with it. So 1 is the charges of an average patient. So you can see that a COPD without any complications or major complications has charges less than the average, is 0.6. Let's take sepsis has 2 severity levels. Remember, some have 3, some have 2, some have 1. And you can see the relative weights of sepsis with and without major complication comorbidity. And then ECMO, there's one ECMO DRG, an MSDRG model, and it's not just for ECMO. So if your hospital doesn't have ECMO yet, you probably have MSDRG 003, because it's also patients with mechanical ventilation greater than 96 hours, or you can read the rest of it here. So it's a good way of trying to understand what your reimbursement might be if you were to get an ECMO program by looking at your current 003 DRG and seeing what the reimbursement is there. Just some other things to note. There's lengths of stay associated with each DRG. The higher the severity, the higher the length of stay. Geometric is kind of like median. It's a statistical method to minimize the effect of outliers. And arithmetic mean is just averages as we know it. So if your hospital is looking to tackle lengths of stay above expected, you have to make sure your documentation is also encoding is appropriate, or you might be looking in the wrong places. If we sort that relative weight table for CMS by highest relative weight to lowest, you see it here. The number 1 relative weight is CAR T-cell therapy at 36. Heart transplant with major complication comorbidity is 2nd. ECMO had always been 3rd up until this year, where it moved down to 4th, and burns went up from, I think, 19 to 26. So still, ECMO is the 4th highest reimbursed service within the CMS MSDRG model, which is important to note. Okay. When we go to the APR-DRG model, which remember most Medicaid programs pay by, and you sort by relative weight, it's all over the map. 3M puts out a standardized relative weight table every year in October. Each state takes it and adjusts it to meet their needs, and adjusts the relative weights, or you can take away or add the DRGs. So in California, neonate with ECMO severity level 4 is the highest relative weight at 26.9. Everything in highlighted in blue is an ECMO DRG. Another thing to note, about 15 out of the 20 of the top are neonatal codes. If you go to Florida and you sort similarly, neonate with ECMO is right up there. But you can see the difference in numbers, right? The severity level 4 has a relative weight of 43.6. California at 26.9. And then you start to see the second DRG in APR DRGs, which is 009. I'll talk about that come into play. It's right there. And then in Texas, everything in blue, once again, is an ECMO code. And look at the relative weight of severity level 4 ECMO. 75.6. So as mentioned, every state has its own variation of the relative weight model. Exact same DRG and severity level 4, 76 relative weight in Texas, 44 in Florida, 27 in California. So it's just important to know when you're comparing one state to the other. There are 2 different ECMO DRGs in the APR DRG model. The neonate with ECMO, which I talked about, you have to be under 14 days of age at admission. They created their own definition of this and have certain birth weights. There's 4 severity levels associated with it. If you're above 14 days of age and you get ECMO, you're going to fall into 009. And if you know about CDI, I mentioned earlier, clinical documentation integrity, that's where you ensure all diagnoses are documented and coded. 009 is the only DRG where it has any impact. Because in MS-DRG world, you see down here, there's only one DRG. There's no different severity levels, so there will be no impact. And then the 583 doesn't follow the normal rules of the encoder. So whether one's a 1, 2, 3, or 4 for this DRG really has to do with whether they had a cardiovascular procedure, or abdominal procedure, or other elements like that, not the traditional CDI impact of increasing relative weight. From 2018 and 2019, CMS did change the rules that if you were cannulated peripherally, you did not fall into MS-DRG 003, you fell into other DRGs, like what surgery you might have had, caused a big uproar, decreased payment inappropriately, and that's been changed. So there are still some revenue cycle folks who don't know that changed, but just be aware that site of cannulation has no impact anymore on this. If a patient receives DRGs, ECMO, they will always fall into an ECMO DRG unless they got a transplant, any kind of transplant, bone marrow, solid organ, then that diagnosis supersedes ECMO and they'll fall into one of those transplant DRGs. But every other patient really should fall here into one of these ECMO DRGs. Just do a time check on myself. And then how's payment determined? So we all learned how we got to a relative weight, right? Which you see there, which is just a scaling of resource intensity of a patient. That number, which comes from our documentation coding, directly will impact payment and will directly impact case mix index. I'll show you that. Let's take neonate with ECMO severity level 4. This is how most DRG payment models are. It's a very simple formula. Base rate times the relative weight, which is 75.95 in this example. Sometimes times an adjuster, some states add another multiplier to it for certain reasons, and then outlier payment, which we'll get to, and you get the total payment. So this is Texas Children's Hospital. All this data is public. You can look at and find the base rates of every hospital within Medicaid state programs. And their base rate is $12,836. For their neonate with ECMO severity level 4, you multiply times that number, they're going to get almost $1 million in payment for this patient, not including an outlier payment. An outlier payment is very important in the ECMO world. You have to make sure your charges are correct. An outlier is a mechanism that if you lose a certain amount of money based on your DRG payment, the state or the federal government is going to pay you some of that back to mitigate the losses. And 60 to 70% of ECMO cases can fall in the outlier payment that we've seen in a lot of hospitals we work with. Your inputs will be different. Your base rate could be different. As you saw earlier, relative weights will be different for the exact same DRGs and severity levels. You might have a policy adjuster, Florida does. Outlier payment thresholds will be different state by state. So this makes it a little more complicated in the APR DRG model when you're looking state by state to try to understand what payment might be. MS-DRG world, which most of your patients are likely going to be in because you're most likely adults with Medicare patients. It's actually a lot easier to figure out what your payment's going to be. You go to this website here, CMS Web Pricer. You can find inpatient. You Google your hospital's CMS provider number, and you enter it there. Put in these other variables, including what the charges might be, and the DRG number. Remember, 003 is ECMO. Price estimate, and it'll tell you exactly what your hospital will get paid for that DRG or whatever DRG you want to enter. And it'll do that because every hospital's base rate is different based on value-based purchasing, readmission penalties, whether they have a GME program, on and on. So it's not a simple base rate like the APR DRG model has. It's the same website. If you scroll down from this page, you'll see your hospital's cost to charge ratio. So this hospital is 22.6. What that means is if something has a charge of $1,000, the actual cost of that is $230. So the lower ratio. So there's some hospitals that we've seen have a cost to charge ratio of 7%. That means that their charges are significantly higher than the underlying costs associated with that. And there's a huge variation from one hospital to the other of what charges are in relation to the underlying cost. And the way CMS and the states determine your actual cost to charge ratio is your hospital required to submit cost reports every year to the regulatory bodies. They then look at your charges and assign a cost to charge ratio to you that will apply for the entire year for all charges in your hospital. You can't say, well, we're starting this new service, our charges are going to be more in line with the actual cost. It doesn't matter. They're going to apply the same cost to charge ratio across the board, and it'll be important later. This is one hospital that we work with, and shall remain nameless, but you can look up yours. The payment formula is very simple, as described earlier. Hospital base rate times relative weight times outlier equals total payment. So remember the ECMO DRG, there's one of them, has a relative weight of 21.3. It's the fourth highest relative weight. Let's just take an example of 700,000 in charges for this case. As mentioned, the base rate varies per hospital. You plug 700,000 in there, and it'll tell you what the payment is for this particular hospital. It's a little bit over 200,000. Let's talk about outlier payment for a second, because that is important. Outlier in government contracts, in stop loss is how commercial payers refer to it. Once again, is a mechanism designed to protect you from large losses. First, they look at the actual cost of care. So where do they get that? Remember that cost to charge ratio? Here's another hospital that's 24.6. Most I see are in the 20 to 35% range. So if there's $1 million in charges submitted for a case, and your cost to charge ratio is 24.6, they're going to tell you your costs of this $1 million charge case is about $240,000. Okay. If based on your DRG payment in Medicare, you lost greater than 42,750, they'll pay you 80% of those losses back. So if your cost was 240,000 and you got paid 150,000 based on your DRG payment, you cross that $42,000 threshold, you're going to get some of it back. That's what outlier and stop loss are. It's a mechanism to prevent severe losses in high resource cases. But is 700,000 an appropriate charge for an ECMO case? Let's look at that. What we see a lot are hospitals not appropriately charging for the true underlying cost of taking care of these patients. You should have an ECMO daily charge that accounts for the training, precepting, the bedside RNs that are always one-to-one, the ECMO specialists, the coordinators, the equipment that you got for ECMO. All of those costs that are real costs have to be accounted for somewhere, and they need to be accounted for in the charges associated with the care of this patient. Then there are additional fixed costs. Hospitals have high fixed costs, 60 to 70% of the cost may be fixed. And then you have to adjust for the cost to charge ratio. And I see a lot of hospitals don't doing that appropriately. If you start a new program and something really costs you $100,000 and your cost to charge ratio is 26%, you have to charge 4 times that real cost to ensure you're not going to get undercut when they automatically apply that cost to charge ratio to you. See, a lot of hospitals don't do that correctly. And we see them a lot not applying all the true costs of ECMO to their appropriate ECMO daily charge. If you look at literature around the country, there was a 2020 study looking at ECMO charges from 2008 to 2016. It was adjusted to 2019 dollars. 824,000 was the average ECMO charges for respiratory failure. This 2023 study looking at 2019 charges, you see the breakdown by region there. And what has occurred from 2019 to 2020 to now? Significant healthcare inflation of 20 to 25%. So everything you see here, we've all lived it. Labor costs and material costs in hospitals have gone up significantly. The charges in your organization need to match that, need to be appropriate for that. And we don't see hospitals adjusting that appropriately. You need to make sure that every day of ECMO is accounted for. These are bedside nurses and ECMO specialists or coordinators who know which days ECMO was started and stopped. That doesn't always get translated to the bill on the back end. So you need to have a reconciliation process to make sure that that's captured and ensure all the other elements that are involved in ECMO care, as you see here, there could be others, are accounted for appropriately and then adjusted properly for your cost to charge ratio, which we see incorrectly done. So say you appropriately charge for ECMO based on a lot of things we just discussed, and you get yourself to $1 million in charges for this ECMO case, you start to see a little bit of outlier payment. Once again, you'll see that in that CMS web pricer I just showed you. You can just start changing the charges from 1 million to 2 million to 3 million, and you'll see what your base payment is, and you'll see what your outlier payment is, and your total payment goes up. If you go to 1.5 million in charges, you'll start to see a significant outlier payment. If you get to 2 million in charges, once again, is not unusual for if you set up your program correctly and charge appropriately. We see this a lot. It charges in the $2 to $3 million range. Your outlier payment exceeds your base payment, and your total payment will actually go up. These are payments. These aren't charges. These are actually what you're going to get paid, and these are for Medicare, which, as we all know, isn't the highest paying payer. So we'll see commercial payers significantly higher than oftentimes. This is the same hospital that, if they're getting $432,000 for $2 million in charges of an ECMO case. What if they didn't provide ECMO for these diagnoses here that are amenable to ECMO? You see, and you can use the same CMS web pricer I showed you earlier and just put in these different DRGs. You see the Medicare reimbursement if they didn't get ECMO, and you see the Medicare reimbursement if they got ECMO. If they're on ECMO for 1 hour, if they're on ECMO for 1 day, they're on ECMO, and the ECMO DRG applies, and this payment applies. So it's really important to note that, okay? And you can see, obviously, the difference in reimbursement. We're doing this for the difference in quality and outcome of the patient, and payment is matching that, of understanding it's a high resource service, and it's increasing with us. On the Medicaid, commercial managed care side, it really, as mentioned earlier, depends on your state's Medicaid program. They have their own outlier thresholds and what gets paid back, but it's an important element of that in the Medicaid model. For commercial, really, I tell hospitals to talk to contracting, go to these payers, and do what you can to carve out ECMO care from your standard reimbursement contract you have with them. These are high-intense, resource-intensive patients. If you have to transfer them out of your hospital to go get ECMO someplace else, that's usually more expensive for the payer to transfer them out. And usually they're going to a regional ECMO center that's likely going to be more expensive because they have the leverage to do that. So you try to negotiate this mid-cycle. How successful you'll be really depends on your leverage and the regional element of what's available in your state or your city. And we at Innovative ECMO have done this, and we can help you with what we've seen at other organizations and what they've been able to negotiate. ECMO coding, there are different codes based on cannulation site, but unlike 2018 and 2019, it doesn't pay differently. So whether it was cannulated centrally or peripherally, VA or VV, that's the cannulation codes. If the patient had ECMO outside of the OR, you have to ensure, we see this error every once in a while, where we have an ECMO case that falls into a non-ECMO DRG, and we look into it, and we see that it was miscoded as an intraoperative ECMO or heart-lung bypass, when even though they actually continued that heart-lung bypass, which now becomes ECMO when they go to the ICU, and it should have been an ECMO code, which put them in an ECMO DRG. So we see that error every once in a while. Transfer patients, which is also important because a lot of these patients might need rehab or a subacute nursing facility or new home health care. There are rules for Medicare and a lot of state programs that if a patient gets transferred into you and they stay 26.7 days, which is the geometric mean length of stay, or they get discharged home regardless of length of stay, you're going to get the full payment as a hospital that was transferred into. If you then transfer them to another site, then you get a partial payment, which I'll describe below. But there's something called the PACT Act or PACT policy, post-acute care transfer policy. Basically what it is if a patient comes to you and they only stay less than the days that were expected to, CMS doesn't want to pay you that entire amount of the DRG. So they'll convert it to a per diem model. So let's continue with that example we did earlier, where the hospital is expecting $432,000 in DRG payment, but they only stayed 10 days. They're going to divide 432 by 10, get to a per diem amount. And they're going to divide 432 by 26.7, which is the GMLOS or geometric mean length of stay for ECMO, to get you a per diem rate, which gets you to $16,180 per day. You multiply that times 10 days, and that's going to be your payment. Okay. So it's really important to understand if a patient gets um, discharged from your hospital to new home health care within 3 days of discharge, or to any of these sites up here, a SNF, a long-term care facility, rehab, and they didn't stay 27 days, this transfer policy is going to apply and you're going to see a decrease in payment. So what you expected, what you see is likely going to be less than you expected. So it's really important for care management and discharge planners to correctly identify and document where this patient's going post-discharge, and that the coding team correctly puts the discharge disposition in the UB04, which is the claim that goes out. And we oftentimes say designate somebody to follow up with these patients, because oftentimes they didn't even stay at midnight at the SNF or rehab facility. They just wanted to go home, or the new home health care that you had been setting up didn't happen. The vendor didn't have any availability, and you had coded it as new home health care, so you weren't going to get full payment. So there are entire businesses that have been created that follow up on these discharges to see if they really got those post-discharge needs, and if not, they adjust the bill accordingly to not get that the lesser payment. Just a few slides left, and we have time. Questions? So professional billing for coding, there's significantly less dollars associated with the professional billing side and the hospital billing side, but it's still important to do. There's codes, CPT codes around ECMO, cannulation, repositioning, and removal, as well as initiation. The same physician can bill for cannulation and initiation. They just have to have two separate notes that support those two bills. There can be a daily management of ECMO code in addition to your standard traditional critical care code, and the same clinician can do it. Similarly, they have to just have separate notes supporting that. We have at Innovative ECMO created a tip sheet that lists all the CPT codes for professional billing, the associated RVUs with them, and this is just a snippet of what that looks like. So we understood quite a bit around the reimbursement model, the documentation, how it impacts reimbursement and the different methods, the per diem, the DRG model. Let's talk about the cost side real quick. Hospital charges or price really is the dollar amount the hospital sets. They usually never have an impact on the actual payment unless you have a percent of charge payer. So if you have a 60% charge contract and you charge $1 million, you're going to get $600,000 paid. Or those charges and subsequent costs put you into outlier or stop loss status, then you're going to get a little bit of it back. And every hospital has a charge master that actually has to be public, that lists the charge. Some states list the charge master on a nice, my state example, on a website, and you can see every hospital's charge master there. There's hospital costs, which is the actual expense incurred to get that service. And the cost accounting is the process of estimating and classifying costs. We talked about how cost and charge ratios are created. There's different types of costs: direct costs that are attributed to patient care departments, indirect costs, or also known as overhead, that are attributed to non-patient care departments. Variable costs are costs that go up or down with volume or the number of procedures you perform. Fixed costs don't change based on volume. And as mentioned, hospitals have a lot of fixed costs. What are some kinds of direct costs that are associated with patient care? Direct costs can also change the volume, right? The bedside nursing, medications you give, the number of studies you do, or implants, that'll go up and down and is directly associated with patient care. That's a direct variable cost. Direct cost is associated with patient care, but doesn't really change, are things like your nursing leaders on a unit. They're working on a unit that's taking care of patients. It's a direct cost, but whether there's 25 patients on the unit or 18 patients, their salary doesn't change. So it's an example of a direct fixed cost. Indirect costs are really overhead, and similarly, they can go up and down. So medical records, housekeeping, right? Those aren't direct patient care costs, and they go up and down based on volume. And these are the overhead costs a lot of us are used to, right? What do you pay your C-suite? How much do you hire consultants for? How much do you pay for IT and marketing and such? Those are the fixed indirect costs. And they're important because your CFO and others are going to look at, does your program have a positive contribution margin, which is defined by your revenue, which we understood where that comes from, your DRGs or per diem, minus your variable costs, which we just learned a little bit about. Your variable costs are the costs that are going to be there because the patient's there. I like to look at contribution margins. Some CFOs and others want to look at net operating income. The difference between that is net operating income brings in all those indirect costs. But those costs are going to be there whether that ECMO patient's there or not. And it's hard to really know the profitability of ECMO if you count for that. So I like to say, like, if this ECMO patient was there What are the costs associated with them being there, and what's the revenue associated with that? And that's truly what your contribution margin should be. We see that in the hundreds of thousands of dollars for Medicare and Medicaid even, and up to $1 million for commercial patients. Once again, it really varies by hospital. Last slide, and we got 15 minutes. I see some chat in comments. So first and foremost, it's clinically important for our patients. We want it available for our community and for our family, for where we live. And it's one of the most profitable services at your hospital. And I hope I showed you that. It allows other high margin services to thrive: neonatal care, trauma, cardiothoracic surgery, you name it. They may not even need ECMO, but the fact that you have ECMO available if needed allows you to keep those higher resource intensity patients at your organization, and you don't have to transfer them out. You have to ensure charges and carve-outs and length of stay are optimized. And as mentioned, there's nuances to, for example, the patient transfer pack that you have to ensure is done correctly throughout the entire revenue cycle. So I will stop there and see what we got in the chat. Carmen asked, how's the base rate typically determined? That's based on each state has a determination based on where your hospital is. There's a cost of living, a wage adjuster. So if you're in LA, you have a higher wage adjuster than if you're in the middle of the state. But that's state determined for Medicaid and federally determined for CMS for Medicare. And as mentioned, it changes based on those variables, whether you have an education program, whether that you have penalties or rewards based on readmissions and such. Will you be able to share this presentation? Yes, this will be posted to the Innovative ECMO YouTube page. Can we charge for oxygenator change beyond equipment charges? Yeah, everything you do should have charges associated with it. So if you're changing the oxygenator and there's labor costs associated with that, you can. My finance department tells me we cannot charge for disposables. I've never heard of that. Disposables are real things you use for these patients. You paid for those disposables. Some hospitals bundle that in to a daily ECMO charge. So in that case, you can't bill for it separately. But if it's not bundled into some other CPT or daily ECMO charge, you absolutely should charge for that real cost that you're incurring. We have an ECMO ICU room charge that has more revenue to cover disposable. Yep, that's kind of what I just talked about. The hospital charge should not be for equipment. It is for higher staffing, training. Disposable is on top of that. Once again, there's a lot of variability from one hospital to the other in how you do that. But once again, the equipment you paid for to do ECMO is a real cost. And nobody expects you to do that for free. And those costs, they do depreciate over time of the ECMO equipment, usually over 7 years, and you have to account for that. But once again, those are real costs that you have to put on some patient in some charge. If a patient is on VA ECMO, is the billing practice to bill for both VA and VA daily management? I think there is different VA versus VV daily management professional bills, but or professional billing tip sheet has that. Would a patient bridge to heart or lung transplant be reimbursed under the transplant DRG, regardless of having been on ECMO or not? Yes, if they ultimately got a transplant, they will move to the transplant DRG, which usually pays higher than the ECMO DRG. But you saw those examples, it varies by state. Awesome presentation, thank you. What is the most important aspect of billing? Honestly, it's getting your charges appropriately in your charge master, getting your daily ECMO charges correct, and that's in addition to your daily ICU room and board charge. We see that incorrectly done often. Can you reiterate what factors affect the ECMO daily charge? It's all of the underlying costs that go with it. Did you hire Innovative ECMO or another consultant to help you start it? You have to make sure those costs are included. ECMO specialists are going to be hired. They need to be trained. They need to have precepting. You might need to have additional equipment you're going to have to buy. Anything associated with ECMO. This isn't ECMO specific. If you start a liver transplant program, there's going to be a lot of costs associated with getting that program up and running, and you have to make sure that is accounted for appropriately. Is there any reimbursement for ECMO 2R. I don't know what that is. If the ECMO system is used for CO2 removal only, can you still charge for ECMO? I don't know the answer to that question, Luca. I believe if you're on ECMO, as we describe it, yes. I've even read that if you're on a ventricular assisted device with an oxygenator added, it kind of acts like ECMO, and you could bill for ECMO in that case. So I know there's a lot of controversy around ventricular assisted devices. Maybe we can have a debate about it here, and whether and in what circumstances you could bill in an ECMO DRG, or there's another DRG called 215. That's for mechanical circulatory support, or someone can move to ECMO DRG 001, which pays even higher. And whether it's a biventricular assist device or not, I hear mixed things about when that can happen. Dominic, you have a question? I see a hand raised. If those are any questions for you? Okay, are you able to unmute yourself if you need to, or did I not allow that? Somebody asked a question about ECMO, hospital bed, cannulas, patient hospital bed, transports patient hospital bed. So I mentioned transports a little bit. I can't speak to the transport cost of it. That will vary depending on payer and what contracts you have. But remember, as I mentioned earlier, the transferring hospital, if they stayed at the transferring hospital for 26.7 days, remember that's the GMLOS of ECMO, that hospital will get full payment. If they left that transferring hospital before 27 days, they're going to get actual payment based on that per diem methodology. And then the receiving hospital, if the actual patient gets ECMO at the receiving hospital, then goes home 5 days later, that receiving hospital who discharged them home will get the full ECMO payment. It's not going to be something that's split among the two hospitals. There was a slide I had that didn't exist somehow, but Nicole, who is Roberts, who's hopefully on this, is an important member of our ECMO team that you can of our team at Innovative ECMO that we'd love for you to reach out to if you want support, if you want us to assess your ECMO program for profitability or other elements or optimization, or you're thinking about starting a new program, we'd love to help you with that, and we can just have a discovery call and conversation with you. What other questions you all have? Oh, yeah, I don't see an unmute button. Sorry about that. Just have to type it in. Let's see. I could unmute you maybe. Any other questions for me? So we have a bit of time. See if I can unmute people. Oh, actually, I can allow you to talk. Raise your hand if you'd like to speak, and I can unmute you. If I can find you, Dominic. Okay, let's go to participants. Dominic, can you talk now?
Can you hear me?
Yes, I can.
Oh, thank you. I think I forgot to lower my hand.
It's okay.
But, yeah, this is something, we have the charges that you've mentioned. But actually going and sitting down with people during contract time and actually see these other different cost ratios. And thank you for this talk, because I mean, this is like a semester in 40 minutes. But actually, like, should we all be sitting down with like our CFOs and going through and actually seeing contract cycles and what are our costs and the ratios?
Absolutely. You should sit with your revenue cycle folks or whoever's in charge of the charge master, that's in parallel. Show me all the charges associated with ECMO, a daily ECMO. Some hospitals have a daily ECMO room and board charge that combines their ICU room and board with ECMO. Other hospitals continue their ECMO, their ICU room and board charge and have a daily ECMO rate on top of it. Make sure it's appropriate. Make sure it's accounting for all the charges you know exist and that is adjusted for your cost to charge ratio. And then you could understand how many ECMO days you have per year to get to a daily ECMO room and board charge around that. And then you also sit with contracting to say, hey, do we have any carve outs with payers? Likely the answer is no. And you need to start talking with them about we really need to, particularly the commercial side. They are used to this. They know hospitals are going to them and asking for carve outs for high resource intensive services like this. And you should be able to have that conversation.
Thank you so much.
Yeah. William?
Yes, hi. My name is actually Jamil. I am in a couple of us are actually watching this from Boston Medical Center. Thank you very much for a great presentation. Just to clarify, the reason that I asked the question about VAV ECMO billing, I was just curious because patients that are on VAV ECMO are receiving both veno-venous and veno-arterial ECMO support. And I had heard some people say that you can charge for both veno-arterial ECMO daily management and veno-venous daily management, veno-venous ECMO daily management. I just wanted to clarify that, whether or not that's something that can be done. The other question I had was, if you say use, for example, a 2 cannula approach like VA ECMO femoral versus using a single cannula approach, like, for example, a crescent cannula. In your note, do you bill for 2 cannulas, meaning 2 insertion of peripheral cannulas if you're doing a 2 cannula approach, and then with the other one you'd bill with 1? Or would you just say bill for 1 insertion of a peripheral cannula?
Yes.
Yeah,
Right.
I'll preface all of it with saying the variability from one compliance officer to the next one hospital is tremendous. So when I say please don't do and then get in trouble for, talk to your team about, but I see this a lot. So to your question about, hopefully you can see the screen still, you cannot, you can't do, from my understanding, 2 different VA and VV CPT code charges. Some hospitals may have it differently, but to my understanding that, and I've talked to our compliance manager about it, you can't do, even if they're getting both VA and VV, you can't do that. If you insert truly 2 separate cannulas, you absolutely can charge, because those are discrete events that you're doing, and you should be able to bill for both those.
Great, thank you.
Yep. Any other? Let's go to participants, see if there's any. Carmen?
Yes, can you hear me?
Yes.
So I had 2 questions. One was, are you able to charge for ECMO standby cases? I mean, we seem to be asked to provide ECMO standby more and more these days, and our coders and finance department tells me, no,
Can you
not able
can
to
you
charge.
explain what that means? So did they actually go on ECMO, or what does ECMO standby mean?
No, we didn't actually go on ECMO, but they have let's say have a challenging case in the cath lab, and they're worried that, and so they have us there with the machine and everything as a standby.
Yeah, I've never heard that particular question, but everything tells me that you cannot charge for that. I guess that's part of the high fixed cost of a hospital, where we have to have a lot of this equipment and emergency equipment in place in case, even if we don't use it. But I don't believe you should be able to charge for something that you never used.
Okay, and then the second kind of refers back again to charges for disposable. At our hospital here, we've been, for many, many years now, we've been told we have to go away from the disposable charges. And so now we have a bundled, like a room charge. But, that certainly doesn't cover patients who are on ECMO for weeks and weeks on end or months on end. And, you're doing multiple circuit changes or oxy changes and things like that. So, I mean,
It just doesn't make any sense to me. Like,
it doesn't to me either, but yeah.
So like if you're actually using equipment and supplies that you paid for, you absolutely should charge for them. Sometimes I see revenue cycle, it's more of it gets more complicated, so they try to bundle things together, and when they bundle it, they don't want things outside that bundle to be line item, but
Right.
sorry, like that's the reality of how you care for these patients. We do lots of labs, we do lots of supplies, and all those things should be charged for appropriately.
Okay, thank you.
Yep.
Very great presentation, by the way. Really enjoyed it.
Hope Candace, did I already call on you? I think I did. Lisa?
Yeah, thank you. There was a question over in the chat, and I was interested in the answer as well. It was, how do you charge for a reconfiguration, like if you're going FEM to IJ or VV to VA, something like that?
I believe that if you look at the CPT professional billing that I have there, it's only 2 pages, there's more than that, that you would charge a new insertion, as an example, of VA or VV, because you'd be putting a new cannula in. And you, from a facility standpoint, the ECMO DRG wouldn't change, but your clinicians who are placing these new cannulas and inserting or repositioning should absolutely charge a CPT code for the professional billing side. I'm going to lower Dominic's hand. I don't think you have another question. Candace, do you still have a Candace, your hand is still up. Did you have a question? No. Lower hand. Any other hands up? Carmen, you there? Nope. Maybe that's it. Let me just check the Q&A.
I'm sorry, I didn't quite catch that.
Oh, your hand was still up, so I didn't know if you still.
Oh, I'm sorry. Yeah,
That's
no,
okay.
my bad.
No, I know
I will-
everybody's learning these different tools.
Thank you.
Yep. I think that's it. And as mentioned, let me just check the chat real quick here. Thanks, Nicole Roberts put it in the chat, her name and email address and where it's going to be posted. So hopefully you can reach out to her, and we'd love to help you formally if you need it. Thank you so much for your attention and for listening. I appreciate your time. Take care.